Hello guys, welcome to Medley and Life. In this video, I am going to discuss about Adenotonsilitis case presentation. Before we are starting the case presentation, the case should be include this all the things. Then only you can easily get good marks. And I am going to discuss about what are all main viva related questions they'll ask during case presentation. First, before we are taking any case, the case should contain general details. The general details means the patient details, the patient name, age, sex, occupation and address, and then presenting complaints, and then past history, personal history, and general examination and local examination. In this adenotonsillitis case, we are going to examine oral cavity and oropharynx specifically because tonsil is mostly present in oropharynx. And then we are going to examine the neck, ear, nose, paranasal sinus because these are all interrelated things. For adenotonsillitis case, if adenoid is involved, it obstructs the eustachian tube, so it leads to ear related disease like otitis media. So we have to examine this neck, ear, nose, paranasal sinus, and systemic examination, and finally diagnosis and management, investigation and treatment. The 11 things should include in your case before you are going to present in front of professors. And we are straightly look the adenotonsillitis case. I am going to take one specific case adenotonsillitis for you, and we'll start. First, it should contain general details of the patient. Example, the master vegetable, aged 6 years, residing in Kandirarathinam, Arilur, studying in first standard, was brought to the ENT OPD by his mother. Informant is mother and reliability is good. Sometimes the informant is maybe their relatives, so the reliability is very poor that time. So we have to check the informant and the reliability. And coming to the presenting complaints. The presenting complaints of this patient is the throat pain for past 1 year and the difficulty in swallowing for 1 year, the mouth breathing for past 6 months and snoring for past 6 months, changing in voice 6 months. The adenotonsillitis case, the most common presenting complaints is the throat pain, difficulty in swallowing, mouth breathing, snoring, changing in voice. We have to write it in chronological order. Chronological order means first which symptom is appeared and which symptom is appeared in last. We have to like that write and present the case. Next, coming to the presenting complaints. In the presenting complaints, we have to elaborate the what is the patient chief complaints. Okay. First, the patient is told throat pain for past 1 year. Here, we have to elaborate it. As told by the patient's mother, the patient was normal 1 year back when he developed throat pain, which was insidious in onset, gradually progressive, intermittent in nature, and aggravated on consuming cold foods and drinks, and is associated with difficulty in swallowing. So we have to elaborate the throat pain. When it is occur, it is progressive or non-progressive, it is intermittent in nature or not, when it is aggravate, when it is relieved. Okay. And coming to the history of mouth breathing for past 6 months, we have to elaborate the mouth breathing too, which is continuous throughout the day with no diurnal or postural variations. The patient's mother noticed that he started snoring while sleeping 6 months ago. Okay. Next, complaints of change in voice since 4 months, that was insidious in onset and worsened during winter. We have to elaborate the voice change also, which is insidious or sudden onset when it is aggravated. Okay. Next, the mother gave history of similar such a recurrent episodes of cold with mild fever that is relieved on taking oral medication. The mother reported a frequency of 4 episodes this year. We have to elaborate the fever also. Maybe it is associated with rheumatic fever or streptococcal infection too. So we have to conclude which bacteria is caused the tonsillitis case. Okay. Next, these are all presenting history. Now we are going to exclude other symptoms also. Here, no history of nosebleeds, nose itching, cough, headache, ear pain, ear discharge, decreased hearing. So we have to exclude nose related issues and ear related issues. In this patient, no history of nosebleeds, nose itching, cough, headache, ear related. This is nothing in the patient. And coming to past history. Past history is important. We have to exclude any other ENT related surgery or any bleeding disease and seizures. Coming to the past history, the patient has been taking medication on and off for throat pain prescribed by a qualified medical practitioner, and no history of ENT or other surgeries in the past, no history of bleeding diastasis, and no history of seizure disorder. We have to include or exclude these all things. And coming to in this past history too, no history of prolonged hospitalization, no history of diabetes, tuberculosis, ischemic heart disease, bronchial asthma. We should mention in this case not a known case or known case. So you don't use no history of. Instead of you use no history of, you have to use not a known case or known case. In this patient, there is no diabetes mellitus, tuberculosis, ischemic heart disease, bronchial asthma. So we have to use not a known case of diabetes mellitus, tuberculosis, ischemic heart disease, and bronchial asthma. Okay. And coming to the personal history. In this personal history, we have to include diet and bowel and bladder habits mainly. So, in the patient, bowel and bladder habits is normal, diet is mixed diet, sleep pattern is normal, no history of decreased appetite. In birth history, uh, in this case, the child is only 6 years. So we have to include birth history, family history, and immunization history. If the patient is adult, you no need to include birth history, family history, immunization history. If it is relevant to the family history, then only you can add the family history. Otherwise, no need. In the patient, the birth history, the child was born by the normal vaginal delivery, which was uneventful. He is the first child of this parents. And coming to immunization history, he is completely immunized till date. And family history, no history of bleeding, diastasis, and similar complaints in the siblings, other members in the family. And coming to general examination. Till now, we are what are all things we see means patient general details, presenting complaints, and past history, and personal history. Now we are going to see general examination. In the general examination, on examination, the child is conscious, oriented to time, place, person, moderately built and nourished. In general examination, we can include systemic examination like cardiovascular system, respiratory system, abdomen, and central nervous system too. And the patient is no pallor, no icterus, no clubbing, no cyanosis, no generalized lymphadenopathy or edema. And in general examination, we have to exclude or include the adenoid related um, problem. If it is adenotonsillitis, okay, the case is adenotonsillitis, so we can know what if the adenoid is involved, the adenoid related facial is present. But if we don't know how we tell the patient is adenoid is involved or not. For in general examination, we have to clearly seen the face of the child. In this face of the child is dull looking elongated face and loss of nasolabial fold and pinched in nose, everted upper lip, crowding of teeth, high arched palate. This is the one of the main important viva related question. What features suggestive of adenoid facies present or not? If it is present, if adenoid is involved. If it is not, only tonsillitis is present. Okay. Here it is the main thing. Features of adenoid. Features of adenoid facies. That is dull looking elongated face, loss of nasolabial fold, pinched in nose, everted upper lip, crowding of teeth, high arched palate. Okay. Then in general examination, we have to mark the pulse rate and blood pressure rate, respiratory rate, oxygen saturation rate, temperature, height and weight. Weight is important because then only we can calculate the drug dose for the child. Here the patient's pulse is normal, 72 per minute, and blood pressure is also normal, 112/76 mmHg. The respiratory rate is also normal, 17 per minute, and oxygen saturation is also good, 99%. The temperature is 98.6 Fahrenheit. It is normal. If you don't have the thermometer or digital thermometer, you can easily write the patient is febrile or afebrile. The height is measured and weight is also measured. And coming to local examination, in the local examination we have to examine the oral cavity and oropharynx. In the oral cavity, the upper limb, lower limb, right and left angle of the mouth, upper and lower jaw, alveolar margin, these are all normal in this patient. If you have any find defect or deviation, you have to mention it. Okay. Then teeth and no loose teeth and the dental formula. Dental formula is not much needed. And vestibule, gingolabial sulcus, gingobuccal sulcus is normal. And teeth is also not important. Dental formula is also not important. The main is vestibule and the gingolabial sulcus, gingobuccal sulcus is normal. And the tongue is color is normal, pink in color. Surface is irregular, contains a papillae, and the bulk is normal too. Movement of the tongue is also normal. And coming to the tip of the tongue is also normal. Frenulum is normal. Anterior two-thirds of the tongue is symmetrical. And the floor of the mouth, hard palate and soft palate, uvula, these are also normal. If you find any congested area, you have to mention. If the soft palate is congested red in color, you have to mention it in congested or edematous. And uvula is, you have to mention congested and edematous. In this patient, it is normal. Coming to the oropharynx. Oropharynx, the anterior tonsillar pillar, right and left is congested. The tonsil is bilaterally symmetrical, uniformly enlarged. The posterior tonsillar pillar can't be visualized because of the enlarged tonsil. We can't examine the post tonsillar pillar and posterior pharyngeal wall. That's why here posterior tonsillar pillar and posterior pharyngeal wall can't be visualized. And squeeze test, Irwin Moore sign is positive. The Irwin Moore sign is we have to in Viva. Most of the question related tonsillitis is they'll ask Irwin Moore's sign is positive or not. Squeeze, what is squeeze test, what is Irwin Moore sign, they'll ask in Viva. The Irwin Moore sign is when we press the anterior tonsillar pillar, the pus is um, the pus is accumulated in the tonsillitis. When we press the anterior tonsillar pillar, the pus is excreted. Okay, if it is present, that is positive. If it is absent, that is negative. Okay, here you can clearly see it is the grade 3 tonsillitis according to the Brodsky grading system. In my professors, they'll grading by the anterior tonsillar pillar and medial surface of the tonsil. But most of the professors, the tonsil grading is based on the percentage, 25 percentage, 50 percentage. Here you can see it is the grade 3 tonsillitis because the medial surface of the anterior tonsillar pillar is lateral to the medial surface of the tonsil, and it does not touching each other. If it is touching, it means kissing tonsil or grade 3 tonsil. So it is the grade 3 tonsillitis. Here you can see anterior tonsillar pillar is congested. Okay, due to enlargement of this tonsil, we can't clearly see in the posterior pharyngeal wall and posterior tonsillar pillar. And coming to examination of the neck. Examination of the neck, we start from inspection and palpation. First inspection, we have to see the neck. The trachea appears to be in midline. There is no visible pulsation, mass, engorged vein in this patient. And in palpation, trachea is position confirmed to be in midline. We have to use 3 fingers to check the trachea is midline or not. And carotid pulse felt on both sides. And coming to jugular-digastric node. In jugular-digastric node, we have to examine 2.5 cm away from the angle of the mandible. We have to palpate in 2.5 cm away from the angle of the mandible. If the jugular-digastric node is enlarged, we can easily find it. In this patient, it is a single, non-tender, round, firm, mobile swelling of diameter 1 cm. Okay. And coming to examination of the other parts, ear, nose, paranasal sinus. These 3 are normal to this patient. And coming to postnasal examination using Stenclair-Thompson postnasal mirror. In the postnasal mirror, we can easily see the adenine posterior ends of the turbinate, opening of eustachian tube, and upper surface of soft palate. And coming to other system examination, I already told we include in general examination, we also include the cardiovascular system, cranial nervous system, respiratory system, and abdomen. Okay, cardiovascular system, S1, S2 here, no added sounds or murmur. In cranial nervous system, higher functions and cranial nerve functions within the normal limits. And respiratory system, bilateral normal vesicular breath sounds heard equally in both sides in all quadrants. Abdomen soft moves with respiration, no clinically palpable organomegaly. And coming to the finally diagnosis. It is the case of chronic adenotonsillitis. Chronic means if it is less than 3 months means that is adenoid. If it is more than 3 months means it is chronic. So the patient developed complaints for more than 1 year, so it is the chronic one. So chronic adenotonsillitis. Here, coming to management and investigation, first we start from non-specific investigation. In non-specific investigation, we have to include hemoglobin, red blood cell count, and total leukocyte count, differential leukocyte count, and erythrocyte sedimentation rate, and also bleeding time, clotting time, platelet count, blood grouping, RH typing, blood urea, blood creatinine, blood sugar, and X-ray chest also. Most of the professors ask why we have to investigate about the hemoglobin concentration, because if it is less than 10% we can't do surgery to that patient, and red blood cell count also. And coming to specific investigation, in this patient we have to take a lateral neck head and neck lateral view of X-ray. We can clearly see the hypertrophied adenoid here, and also tonsil also. Then diagnostic nasal endoscopy we have to done to find the enlargement of the adenoids, and get a throat swab for culture and sensitivity. If we find which bacteria is caused, then only we can clearly give that specific drug for that bacteria, so it can easily we can cure that patient. And coming to treatment, first conservative treatment and then surgical treatment. In conservative treatment, it is the medical management. We try to give drugs to reduce the enlargement of the tonsil and adenoid. If it is not reduced, then we are going to surgical treatment. In the surgical treatment is adenotonsillectomy under general anesthesia. And this is the presentation of the adenotonsillitis case. I try to include what are all things we have to include during the case presentation. And coming to what general viva related questions about adenotonsillitis case. Mostly the professors they are asking about the surgery related questions. Okay, first they may be asked about the tonsillar bed structure. What is the tonsillar bed structure from medial to lateral? And then ask about adenotonsillitis, acute tonsillitis and chronic tonsillitis, and stages of the tonsillitis, if it is parenchymatous, follicular, or it is membranous. And then tonsillectomy. Tonsillectomy, they ask which position they used for the tonsillectomy, and which position they used for the bronchoscope for removal of the foreign body. Most of the time they ask about difference between the rose position and barking dog position. So we have to know about the which position they are used for the tonsillectomy and bronchoscope for foreign body removal. And then ask about complication. What are all complications occur during the tonsillectomy? Immediate complications. What are all immediate complications? What is the delayed complication? They'll ask about, and know about the what is the procedure during tonsillectomy surgery, and what are all instruments we are used in our surgery, and what is the indications of the tonsillectomy, and what is the contraindication of the tonsillectomy, what is adenoid, where it is located, and then what is the adenoid faces features, and how we are going to grade the tonsillitis, and what is the blood supply of the tonsillitis. These are all mostly viva related questions related to adenotonsillitis case. Before you are going to present adenotonsillitis case, you have to know entire tonsil anatomy and clear case, and then know about the surgery procedures. Okay, that's it. Thank you. Subscribe to my channel and share to your friends.